Hi there, and welcome to We Talk Science. Here's another podcast from us. Today I have the honor of interviewing Professor Tom Coenye from Ghent University. Hi, Tom. Good morning. How are you doing?
Hey, good morning, Shiva. I'm doing fine.
Thank you so much for your time today. Really looking forward to hearing all about you. So tell us all about you. Where do you work? I just said Ghent University, but of course you have a whole history about that. What do you work on? What are you excited by? Go ahead.
All right. So, as you said, I work at Ghent University in Ghent, in Belgium. Actually, I work in the Faculty of Pharmaceutical Sciences, where I run the Lab of Pharmaceutical Microbiology. We're a group of about 20, 25 scientists, and we mainly work on what I would call social microbiology. That's the social behavior of microorganisms, how they interact with each other, how they communicate with each other, how they interact with their human host. And one of the things we specifically work on is biofilm formation in bacteria, the way bacteria can form elaborate three-dimensional structures that present certain challenges when treating infectious diseases. So that's, in a nutshell, our main scientific interest.
So tell me more about biofilm. So bacteria don't grow by themselves. They don't grow as single-celled organisms because, we all learn in school that bacteria are self-sufficient in their single cellular structures, but they don't actually grow. They grow in communities, basically. Is that what you're saying?
Yeah, so the paradigm has for a very long time been that bacteria live as these single-celled organisms that live in suspension, that don't interact much with each other. So we talk about planktonic bacteria, and of course bacteria can live as in a planktonic state, and in many cases they do. But what we see is that under normal conditions in the environment, but also in vivo in the human body, bacteria will form aggregates, will form more complex three-dimensional structures that we call biofilms when they are given the opportunity. And so these biofilms can take many forms. They can form on a surface. Think of, for example, the gooey stuff you find on your teeth in the morning. That's a biofilm. So dental plaque is a biofilm. But bacteria can also form what we call suspended biofilms, which are aggregates of cells, several hundred micrometers, sometimes several millimeters in size, that are non-surface attached. And one of the reasons why we are so interested in these biofilms, in these multicellular structures that are formed by bacteria, is because the properties of the bacteria in biofilms are very different from the properties that planktonic cells have. And so, for example, we know that it's much more difficult to kill bacteria in a biofilm than it is to kill planktonic cells. And that has very important repercussions for treatment of infectious diseases, because we know that the majority of bacterial and also fungal infectious diseases are actually caused by biofilms and not by planktonic cells. So this has a huge impact on how we look at bacterial and fungal infectious diseases, and also on how we approach treatment of these infectious diseases.
Okay, let's go a little bit deeper into this particular issue about, obviously resistance of biofilm or bacteria in biofilm and fungi in biofilm to convention the medication, basically the medicines that we have against them. Why does this happen? Is it just a physical sort of structure that doesn't allow the medication to get into the biofilm, or like what exactly? What are the properties? Can you define that a little bit more?
Yeah, so there's a number of reasons for it. First of all, we the term antibiotic resistance is used frequently, and but probably in this particular case, it's not the best term, because what happens if you imagine you have this cluster of bacteria attached to a surface, and if you try to kill them with antibiotics, you will find that you need much higher concentrations, you need much more of the antibiotics before you can actually kill these bacteria. However, if you would take the individual bacteria out of the biofilm and expose them to the antibiotic, they would just as readily be killed by the antibiotic as a planktonic cell. So most often it's not an intrinsic property of the cells in a biofilm, but it's the entire thing that provides reduced susceptibility to antibiotics. And we prefer to use the term antibiotic tolerance in this regard. So tolerance and resistance are two different things. They both result in failure of antimicrobial therapy. So that's what they have in common. So there's a number of reasons why microorganisms are tolerant when they grow in a biofilm. One of them is, and you already mentioned this, is the physical aspect. You have the biofilms packed, the biofilm cells packed tightly together, encased in a slime layer, what we call the biofilm matrix. And for many antimicrobial compounds, it's much more difficult to penetrate into such a structure than it is to reach individual planktonic cells. So that is definitely something that needs to be taken into account. However, that's not the case for all antimicrobial products. Some antimicrobial products actually penetrate quite well into the biofilms, and still we see this biofilm tolerant phenotype. And the reason for that is that bacteria, when they're in a biofilm, they behave differently. Their behavior is different compared to that of planktonic cells. And that difference in behavior can manifest itself in many different ways. One of the things that we often see in biofilms is that they're metabolically less active. There's a number of reasons for it. You can imagine if you're packed closely together with a lot of bacteria, that you quickly use up all the nutrients, you quickly use up most of the oxygen that is in your environment. And what happens as a consequence of that is that the metabolism of the bacteria goes down. They become almost dormant, not completely, but they become less active. And we know that many antibiotics actually need metabolically active cells to be able to kill them. So if your cell is not active, if your cell is sleeping, if your cell is dormant, then antibiotics work much less. And this is one of the important reasons why we see this biofilm tolerance to antibiotics.
That's really interesting. So basically, what you're saying is bacteria just literally behave differently when they're accumulating together in communities, and that presents, a bigger challenge essentially to being able to get rid of them. Could you give us an example of this in a real life sort of situation, Tom?
Yeah, I mean, there's a couple of very well-known biofilm-related infections. Maybe I can give two of them. So one is respiratory tract infections in patients with cystic fibrosis. So cystic fibrosis is a hereditary disease, and patients with cystic fibrosis have very sticky slimes in their lungs. So the mucus is very viscous, and this forms an ideal breeding ground, to use that term, for many different bacteria. And what actually happens is that the bacteria, and most often we find one particular bacterium, Pseudomonas aeruginosa, in the lungs of these patients. What will happen is that these bacteria will form these aggregates, these biofilm clusters in the sputum of cystic fibrosis patients, and that makes it virtually impossible to eradicate them from the lungs. A second example is chronic wounds. Chronic wounds can result from non-healing wounds after surgery, can be associated with diabetes, or can be found in elderly patients. And very often we see that the fact that these wounds are non-healing is because they have been chronically infected with bacteria. And also in that case, if you take biopsy samples and look at them under the microscope, you will see that the bacteria are present in the form of these biofilm aggregates. And maybe a third example, because I think that might be a good example to show a different kind of biofilm-related infection, is we know that many infections associated with medical devices are biofilm-related. So, for example, if patients get an artificial knee or a new hip, during surgery, that material that is implanted can become contaminated, and the bacteria that are attached to that prosthetic device can form a biofilm. And this also happens on catheters, on both central venous catheters, urinary catheters. All kinds of medical devices can become colonized by biofilms, and this often requires the removal of the medical device, and that is relatively easy in case of a urinary catheter. It's of course much more difficult if your prosthetic knee is contaminated. So that is a big problem in that regard as well.
Okay, interesting. Very interesting. So, the problem is quite serious. So I know that there are several groups that are working on alternatives to trying to disrupt biofilm. In fact, you actually just published a paper about that as well. Could you tell us more about that, actually?
Yeah, so many people, of course, are looking at, because we know that the conventional antibiotics often don't work as well as we would like them to against microbial biofilms. A lot of people are working on alternative approaches, and so one of the things we did recently is so I mentioned that sometimes it's difficult to get antimicrobial agents, antibiotics into the biofilm because the cells are densely packed. You have this slime layer surrounding them, so it's not easy to get stuff in there. So one of the things we thought of is, well, if we can now loosen up the biofilm structure, if we can make it more easy for antibiotics to penetrate into the biofilm, make it more easy for antibiotics to reach the bacterial cells, we might get a better effect with the same concentration of antibiotics. Of course, that's easier said than done, because how do you do that? And that's when we teamed up with a group of physicists, and they were working on using gold nanoparticles and the properties of gold nanoparticles for various applications. And one of the properties of gold nanoparticles is that if you hit them with a pulsed laser light, they will heat up very quickly. But because they are so small, they will immediately transfer all that energy to the surrounding liquid, and that surrounding liquid will immediately start to boil and evaporate. And what happens if liquid evaporates? You have a bubble, and that bubble will grow and will then explode and create a shock wave. And so what we wanted to do is see if we could use these shock waves, which we call vapor nanobubbles, if we could use these laser-induced vapor nanobubbles to loosen up the biofilm structure. So what we did is we exposed biofilms we had grown in the lab to gold nanoparticles, and these gold nanoparticles are very small, 60, 70 nanometers, so they could easily penetrate into the biofilm. They did not interact much within the biofilm, so that was good. And then we hit them with a laser light, and so what we saw indeed is that you get these vapor nanobubbles that form in the biofilms, and that loosen up the structure of the biofilm. And if we combine that exposure or that treatment with gold nanoparticles, laser light, and antibiotics, we actually see a vastly increased efficacy of these antibiotics. It depends a bit on what kind of antibiotic you use in the biofilm, but in many cases we saw more than 1,000 times more killing of bacteria with that approach than if we would have used antibiotics alone. So this is one of the many approaches we use. In this case, it allows us to provide better access of the antibiotics to the cells.
That's really incredible. Can you talk more about like the context of, for example, the cystic fibrosis patients that you mentioned, or perhaps even the knee prosthetics that get contaminated with biofilm? How is this particular technology? How could this particular technology be applicable in these situations?
Well, that's a good question, a very relevant question. Of course, it's not easy to translate this concept into something that is readily usable in the clinics. But one of the applications we had in mind, I talked about chronic wounds. Obviously, chronic wounds are on the outside of the body, so it's actually quite easy to imagine that we could use this concept for the treatment of chronic wounds, especially since in dermatology the use of lasers is well accepted. So this could be one possibility. Another possibility is trying to switch to, we now use the green laser light, which has a wavelength that doesn't penetrate very well into tissues. What we could imagine using other types of gold nanoparticles that will actually absorb light of another wavelength. For example, infrared laser light. And we know that infrared laser light penetrates quite well into tissues, sometimes up to a couple of centimeters. And so that might allow us to reach regions that are deeper inside the body without having to go to surgery. But of course, these things need to be investigated. In the context of cystic fibrosis, you could imagine going in with fiber optics. These things have been explored in the past. So with fiber optics, you could potentially deliver laser light of the right wavelength into the lungs. So there are some possibilities, but the technology, of course, has to be developed in order to be able to do that, of course.
Yeah, sure. Now, as it seems to be a lot of really exciting work that is going on into this really serious problem. So, I think this is really, really interesting for me as well as for our listeners. Okay, can we change gears here a little bit? As a microbiologist, we are, of course, in the middle of a pandemic these days, and that has vast-reaching global effects. I find that people are very confused as well about the incredible amount of information that is coming out, both from credible and not so credible sources. What is your take on the coronavirus, COVID-19, SARS-CoV-2 situation? Like, what are your immediate sort of frustrations and it's basically how do you address this with your family members, for example? Because I'm sure they're coming to you to ask you about what is real and what's true, right?
Yeah, well, it's been a very frustrating situation for us as well, of course, just as for everyone, I can imagine. So, but luckily, I mean, I think one of the good things is that at least here in Belgium, we went in lockdown mid-March, and we slowly starting to see the end of the light at the end of the tunnel. So we see that all the measures that have been taken had an impact, a positive impact, and so that's of course very reassuring. But I think the frustrating thing is to see, of course, that science is of course what should drive decisions. Science should be what drives decisions on how do we deal with this pandemic, how will we prevent that it happens again, what is the best way to treat patients, etc., etc. So basically, every decision you make should be based on science, and that turns out, and that's probably the big frustration. Two parts of it, two parts to it. I mean, first of all, is that since this is it's a new virus, and we don't have any experience with what is happening right now. I mean, the last time something of this scale happened was in 1918 with the Spanish flu. So, I mean, there's not like a set of instructions that we can follow to get out of this mess. So that's one thing that is frustrating. So we don't have all the science and all the knowledge in place to help us deal with that. But secondly, of course, it's also the way science is being used or not used in this pandemic, and this goes to various aspects. I mean, it goes to I cannot. I mean, I don't want to talk about this, but I cannot ignore this. This goes about people advocating the use of hydroxychloroquine, which is a drug that has been used for malaria. There's no evidence that it actually works. It's not the most safe drug. But then people, including the President of the United States, start to push its use without evidence. So these kind of things make me, it's very frustrating as a scientist, because you know that also scientists and politicians and the people in power bring out information that is not correct, or at least that has not been verified, and that adds to the confusion. And that makes it much more difficult then for the lay public to understand what is going on, but also makes it much more difficult for them to accept proven scientific facts later on. And that is a big frustration.
Because you see, the thing is, proven scientific facts also change over time, of course.
Yes, that is true. That is true. That's inherent to the process of science, right? I mean, we had when this whole thing started in late December in China, in Wuhan. I mean, very few people were worried about it. I mean, very few people knew about it. I think the infectious disease people heard about it, and we knew something was going on in Wuhan at the end of December. But I think very few people thought it was something to worry about. I mean, we kept an eye on it, but I mean, again, the last thing something really bad happened was in 1918. So why would we worry about that? But then, as time progressed, and in the course of January, and then of course in February, we saw it was something that was much bigger. And while people initially said, well, it's not going to be much worse than the flu, I mean, it obviously became clear that this is nothing quite like the flu. But that doesn't mean that people that said, oh, this is going to be something like the flu, were lying. I mean, they based their judgment on what was known back at that time in late December, early January. So we learn as we go along. And this, of course, I can imagine that this is sometimes confusing for people because they say, well, 3 weeks ago you said this, and now you're saying something else. Well, that is because 3 weeks ago I didn't know what I know today. And this is the normal process of science. That's what we do every day. We're used to doing that. But I can see how that can be confusing for people that are less familiar with the way science works.
So, what is, I guess my last question would probably be, what is your recommendation for people on the street that are, again, being, bombarded with all of this information? How do you suppose, like, for example, if it's a family member or, somebody that you know, a good friend, well, what would you tell them in order to distinguish between, what to believe and what not to believe, in anything? I mean, not just the coronavirus, but in any sort of science that comes out these days.
Yeah, that's difficult. I mean, I think we have the luck. I think here, at least in Western Europe, that we typically can in this regard can trust what our government is saying. I don't think the governments and the public health officials are lying to us on purpose. Absolutely not. Of course, they are limited to the scientific knowledge as well. So they themselves may say something today that turns out not to be true within 3 weeks. But again, as I told you, that's I think how science works. I think we have to be very careful with this. I mean, there's a lot of misinformation that is out there, and it's extremely difficult to sometimes it's even difficult for trained scientists to make out what is correct information and what is misinformation. And misinformation may come from various sources. I'm sure there are people that put out misinformation on purpose, for whatever reason. There's also people that put out misinformation but genuinely believe that what they put out is not misinformation but the truth. I mean, for example, conspiracy theorists. And then there's the more, what I would call the gray zone. And a prime example of that is the whole debate about whether you should wear a mouth mask or not when going out in public. There's a huge body of literature on that, and it's extreme even for scientists. There's no consensus. I mean, it's extremely difficult to formulate a scientifically sound advice. And typically, in that regards, I mean, we want our medicine to be evidence-based. If we bring a new drug to the market, we want to be able to, we can only do that if we have shown that it's safe and that it works. That's the way medicine typically works. Now, this whole debate on mouth masks, you have the first of all, is there evidence? Not so much. There's no convincing evidence that if everybody wears a mouth mask while going out, that would actually reduce the epidemic. That has never been shown. But then on the other side, you have the perception. People say, well, it must do something. And even if it doesn't do anything good, it will not do any harm. And there the discussion starts, because probably, I mean, there is some evidence that if people wear mouth masks, they will touch their face more. They will probably put them, a lot of people will not use them the right way. And so they will give a false feeling of security. And so something which is ultimately very simple, wearing a mouth mask, becomes a debate between scientists, saying, well, there is evidence, there's no evidence, it's maybe yes, maybe no. And so even if scientists don't agree on that, and that's normal. I mean, again, this is what happens in science every day. I can imagine it becomes very difficult for the lay public, for the broad public, to understand what is going on. And this is also one of the frustrating things. I mean, you try to give advice to people based on scientific evidence, and if you do that, I'm using it as an example, but I think it's a good example. If you do that for the whole mouth mask debate, you have to say, well, there's no evidence that they work for you, and there is some evidence that they might actually have some unwanted disadvantages, but the government is making it mandatory, at least here in Belgium, starting off today, to wear them on public transport. So yes, you have to do that. And so you have to give all these nuances and say, well, yes, because there's many people on public transport, it might actually be beneficial, but it might not be beneficial or disadvantages when you go to the supermarket. So what we see here is that even very conceptually very simple things, you should or should not wear a mouth mask, become very complicated. And this to me also shows how difficult it is to translate scientific research and scientific evidence, or the lack of scientific evidence, into something that people can readily understand and can apply in their daily lives. And yes, I mean that's so. So coming back to your original question, what do you tell people? I mean, I I think the best advice in this situation you can give people is to follow the advice from public health officials, follow advice from the government, because they make decisions based on what the scientific consensus is on this moment. Uh, but don't be surprised if that advice changes in a few weeks, or if that advice is different from what they said a couple of weeks ago. Again, this is how science works.
Thank you so much, Tom. There you have it, guys, straight from the horse's mouth. In this case, a very well-known and respected microbiologist. Tom, this has been such a pleasure to talk to you. Thank you very, very much for your time.
My
Uh,
pleasure.
thank you. And for all our listeners out there, stay tuned. There'll be more where this came from.